Welcome back to Einstein's Eyes, everyone. It's great to have you back. The curious folks that we have on our channel. I'm Carl Rosen. I'm oculoplastics and neuro-ophthalmology in Anchorage, Alaska. Been here for many years. Fellowship trained and board certified, just for those who are asking. Today, we're going to dive into the topic that's crucial for anyone with macular degeneration. Intraocular injections and there's a number of, we call anti-VEGF injections for macular degeneration. The VEGF is vascular endothelial growth factor. You don't need to know that, but we have a special guest, Dr. Chad Bouchard. Chad's a partner of mine at the Surgery Center, Geneva Wood Surgery Center in Anchorage. Chad's got the background there. Looks good. Looks good. I'm inside, he's outside.
Right.
And I'm gonna let Chad introduce himself, but we're gonna switch over to John. John, say hello.
Hi, this is John Ditkoff. I'm a general ophthalmologist specializing in cornea in northern New Jersey. Carl and I met each other many, many years ago at Albert Einstein, a residency program in ophthalmology. Hence the name of our YouTube is Einstein Eyes. And I'm excited to hear about injections to the eye. I guess not just for macular degeneration, but some other issues too. So we'll talk about it.
Right. And so I'll just get back to Chad. Chad's our special guest. Chad's actually been on the channel before. A lot of people liked him. Our good-looking, handsome retina doc in Anchorage. We don't have many of them. But Chad, I should say Chad was a major in the Army. Thank you for your service, Chad. And
all right, thank you.
Why don't you say hello to our audience?
All right. Hey, everybody. Nice to be here again. Like Carl was saying, my name is Chad Bouchard, so fellowship trained, board certified retina specialist. And here to talk about intravitreal injection. So it's a very, very frequent very frequent procedure that we do every day in the clinic. And it has revolutionized the way that we treat conditions that you may have heard of, such as macular degeneration, age-related macular degeneration, diabetic macular edema. Those are the two most frequent. Won't really get into the full biochemistry of what these drugs are. As Carl was mentioning, VEGF, vascular endothelial growth factor. Well, these are the anti-VEGF type medications, and there's a whole host of them: Avastin, Vabysmo, Eylea, Lucentis, and now there's newer ones called biosimilars that are becoming more and more available. And so if you're the patient walking into the clinic and you've been told that you have macular degeneration and you're going to need eye injections, well, the first thing that we typically start with is discussing the condition, why we're treating the condition. And as we get into the eye injections, patients are very, very scared, of course, as they should be. It's very quick. It takes about a second to do the injection. Various ways that we anesthetize the eye. Most frequently, we'll use a little lidocaine underneath the skin of the eye. I like to do eye drops because it's quicker. And we clean the eye with betadine. All right, so this is a kind of a classic setup that we'll use. Now, when we started injections, we use very elaborate setup with draping the patient and having the patient use antibiotic drops a few days before. Over time, we've actually streamlined things to more simplistic use. And we don't need antibiotic drops beforehand. In fact, we don't want them to be used because it could create bacterial resistance. As we'll see here, we have got an eyelid speculum. We have some Q-tips. We've got some syringes, the medication, and some needles. And the needle is very small. It's a 30 gauge needle. We're probably one of the only specialties to use such small needles, in fact. When people think, oh, I'm going to get an injection in my eye, they think this is going to be a big needle. It's going to go way into my eye, and I'm going to be in so much pain. Well, the fact is, it's an extremely small needle, and very rarely do patients experience pain. Mostly they feel pressure. And the reason why they feel pressure is because the eye is a contained substance, right? There's a certain volume, and we're increasing the volume by putting 0.05 milliliters. So it's a very, very, very small amount into the eye. So it does create a little bit of pressure, a little bit of blurring of the vision for a very short period of time. So this is what it looks like. We use an eyelid speculum to keep the eye open. And you can see here that the eye has been cleaned with betadine. The betadine concentration that we use is 5% betadine. We use a couple of eye drops. It's all that we need. One eye drop before the eyelid speculum. Once the eyelid speculum goes in, we put another drop. We want to give it appropriate kill time, if you will. So it's on there for about 15, 20 seconds or so. And the injection is done about 3.5 to 4 millimeters posterior to what we call the limbus. And that's the as Carl's pointing out there with the cursor, the anatomic location between the edge of the cornea and the start of the sclera. And we do that based on if you've had cataract surgery, if you have not had cataract surgery, etc. It's given in the avascular plane. So anatomically speaking, it's given in the pars plane, where there's no blood vessels. Okay, so theoretically, what are the biggest risks, biggest complications that could arise from these injections? And the number one concern is infection. Fortunately, it's very, very rare. About every, say, 3 to 4,000 or so injections could result in an infection. Betadine gives us the appropriate aseptic technique to prevent infections. Okay, and the most important thing too is to limit communication with the patient while you're doing these injections because of sputum and bacterial, such as strep pneumo, for instance. There's a very, very virulent bacteria. But nevertheless, they, as I mentioned before, they've revolutionized how we have treated these conditions. And without them, patients simply would lose vision, go blind. So we do several hundred per week.
So, it seems like right now my patients, we have a retina specialist, and it just seems like there's so many different medications. There's also, I don't know if you guys get this ad in Alaska, but Henry Winkler. Do you hear this ad all the time or no?
No.
We hear on a regular basis an ad, Henry Winkler, the Fonz from the Happy Days.
Yeah.
He talks about his father-in-law or mother-in-law that had atrophic AMD and had this new medication for atrophic AMD.
Yeah.
But how do you decide which medication you're given?
So every patient that comes in gets a certain scan called an OCT, and that scan highlights the very detailed area in the macula, the area of concern. So, for instance, patients with macular degeneration, the dry form versus the wet form. Most frequently, it's used for the wet form, where you have blood vessels growing from underneath the retina. They leak, they can bleed. The newer treatment for the dry form, the newest to be FDA approved, slows down that atrophic component. So it prevents the loss of tissue. The tissue loss is very small. It's 0.5 millimeters squared per year. And these medications, they can decrease up to 30% reduction in that atrophy. So other conditions such as diabetic edema, uveitis, of course, if there is an infection, using antibiotics in the eye, antivirals, antifungals. There's also drug delivery implants, steroid delivery implants that are available that we use frequently.
Do you have problems getting approved for some of the standard macular degeneration injections? Like some of them are very expensive.
Some are.
And then like Avastin is much less expensive. You have problems.
Yeah. Not particularly. It depends on the insurance company. So most frequently we see Medicare patients and we don't have to get prior authorization. Avastin is the most frequent that we'll use for other, commercial type of insurance plans. That's what they prefer us to use. They call step therapy. So they want us to use, in fact, Avastin is not even FDA approved for use in the eye. But because it's the cheapest, they want us to use it. Now, the more durable medications, so they're not more efficacious, but they're more durable, such as Vabysmo and Eylea, for instance, and even the newer Eylea HD, which is 8 milligrams. They can allow us to extend the treatments. So classically, I'll tell patients, the longer you're on it, the less you need it.
Yeah.
Because we start at a 4-week interval, and then as you're improving, then we extend the treatments. We do treat and extend. So I go up 2 weeks, and then 2 weeks, and 2 weeks. So you're at 6, 8, 10, 12 weeks. And at one point, you're at 16 weeks or so in between treatments.
Yeah, that's nice.
And Other patients, will try what we call an injection holiday and try them off the medication. The other thing I tell patients is it could be 1.5 to 2 years of treatment before we can consider stopping. Simply, if you do the math to get to the point to where there are 3 months in between treatments with no new activity, well, in that scenario, we may try an injection holiday.
I think that's important for anyone viewing this. And a lot of my patients will ask me, like, I had the injection, am I done? And I have
That's
to
right.
explain to them that, this requires 1.5 to 2 years of continued monitoring and treatment to really quiet down this neovascular, new blood vessel growth and new bleeding. And that if they just have it done a few times and they stop, they're putting themselves at significant risk.
Exactly. And if it was a pill that people would take, they would never ask the question. And a lot of people come and say, if I had 2 or 3, right, I'm done, aren't I? And it's, no. We talked about this. Of course, that first appointment, it's like sipping water through a fire. It's a lot of information. But it's very helpful.
Yeah.
And the most frequent thing, I should note this, the most frequent thing that could arise right after an injection, patients will experience some irritation. They'll see the medication floating around, so they'll have a floater. And then it's very frequent to where there's a lot of blood vessels in the location that we go. And so they may have a little red spot. I always tell people, I hit a blood vessel, it's an innocent bystander, it's just a bruise. It's going to go away.
Yeah, so that's great. That's great. Anything else, John?
No, that was really wonderful.
Yeah, Chad. No, thanks a million, Chad. That was great. I think our
Yeah.
audience will appreciate that. So, in summary, Avastin and other anti-VEGF injections really offer promising treatment for wet macular degeneration and other issues, as Chad was talking about, diabetic edema, central retinal vein occlusion, edema, that kind of thing. So, there's a good balance between efficacy and safety, and your retina specialist will adjust that accordingly. During the consent process, you'll understand that with your retina specialist. But you need to talk to your eye care specialist, obviously, about this treatment and make sure it's right for you. But thanks for watching Einstein's Eyes. Please don't forget to like and subscribe, and we will see you on the next one. Stay tuned for more insights into eye health, innovation, policy, and wellness. Thanks a million, guys.